plus infracarina synchronous esophageal case. Please.
Thank you for your introduction. First of all, I want to mention there are 4 scenarios in patients with synchronized head and neck esophageal cancer: early versus advanced head and neck cancer, resectable versus unresectable esophageal cancer. Also, the esophageal cancer has a problem of tumor site. I think the treatment sequence or approach is based on the severity of cancer site. In this case, the primary tumor is mainly located at base of tongue, did not invade to parapharyngeal space. Perhaps it's resectable, but reconstruction is a tough job. The lymph node is necrotic and adhere to carotid artery. So I think it's very difficult for ENT surgeon to completely remove the tumor. In contrast, the esophageal cancer is categorized to T2 or T3 N0 esophageal cancer. So it is resectable esophageal cancer. So the combination is advanced head and neck cancer and the resectable esophageal cancer. There are 4 treatment options for this patient. My preferred treatment is option 1, the finished CRT for basal tongue cancer, plus simultaneously CRT for esophageal cancer. If we consider the toxicity of the option 1, we may consider the finished CRT for basal tongue cancer and the plus sequential surgery for esophageal cancer. But I think once the diagnosis of esophageal cancer is made, a few patients or family can tolerate the further treatment of esophageal cancer. So I think it's not feasible. The third option is induction chemotherapy with taxane-based regimen followed by CRT for both cancer. I think this practice may be applied to head and neck cancer, but it is not. The evidence for resectable esophageal cancer is not enough. So I think this is based on a clinical trial to document the roles of the option 3. The fourth option is induction chemotherapy with taxane-based regimen followed by surgery for both tumors. But this depends on the responder to drug. For non-responder, I think it's not a good choice. So, what is the regimen I suggest? I would like to suggest weekly cisplatin or tri-weekly cisplatin. If we chose the PF-based regimen, the dose should be reduced to avoid the severe myositis or esophagitis during treatment. And if we consider taxane-based regimen, I think it's based on a clinical trial. And after the radiation, I will suggest the clinical assessment and follow image 1 to 2 months after radiation. And if the basal tongue tumor response is good, we should choose second treatment option is close surveillance of this patient. Of course, we can consider sequential esophagectomy because it is not belong to very early stage esophageal cancer. Of course, the patient condition should be stable and fail. If the basal tongue cancer response is not very fair, I think we should consider self-operation for residual basal tongue or neck tumor. But I think it's a very tough job for ENT surgeon. The radiation technique, I would like to suggest SIB-IMRT for basal tongue cancer with 70 grade to primary tumor plus nodal region. The prophylactic lymph node should be minimized to avoid the severe toxicity. For esophageal cancer, I would like to suggest IMRT or 3D CRT for esophageal cancer with prescribed dose of 50 gray to interfere, not includes whole esophagus. This curve shows the outcome of local control of oropharyngeal cancer after definite CRT in IMRT area in our hospital. The right side is basal tongue, the left side is tonsillar cancer. We can see when tumor was stratified with T1, T2, and the T3, T4, the local control of basal tongue cancer is very poor when compared to the analog of tonsillar cancer. So I think eradication basal tongue cancer is the top job for radiation oncologists. Also, I think this patient have other two poor prognostic factors. First is high SBU maximum. The SBU maximum for this patient is 18. The second is necrotic negative node. This study is conducted in our hospital. We analyzed the 70 patients with pharyngeal cancer, and we find the local control of when tumor was stratified with high SBU maxima and low SBU maxima. We find patients with higher SBU maxima have poor local control compared to low one. This is our recent study according to the analyze the nodal control of metastatic lymph node. When the lymph node was stratified with CT-based central necrosis, we can find the necrotic lymph node had poor outcome when compared the lymph node without necrosis. So, putting all those together, I think the probability of control of basal tongue for this patient is less than 50%. But if the basal tongue cancer responds well to the CRT, what is our next step? This is the meta-analysis compare the radiation birth surgery for resectal esophageal cancer. We can see the overall survival is equivalent between the two modalities, but there is trend to more cancer deaths in definitive CRT arm with hazard ratio of 1.2, mainly due to higher local regional progression. So I think if the condition of this patient is very fair, I would like to suggest consider the possibility of sequential esophagectomy. Also, the meta-analysis published in Lancet Oncology, we can compare the survival with surgery versus neoadjuvant treatment plus surgery. For resectal esophageal squamous cell carcinoma, the hazard ratio for all-cause mortality for neoadjuvant CRT is 0.8, while the all-cause mortality for neoadjuvant chemotherapy is 1.9. So the best choice is for esophageal cancer is still neoadjuvant CRT followed by surgery. Okay. Many audience make question about the efficacy and toxicity of combination treatment when irradiation field include both sides. The first study published 9 years ago from Germany, in a cohort of 24 patients, some of patients were treated with operation. We can find they report a very satisfactory 3-year local control and survival and the local control. Another study published 3 years ago from Japanese group Kyushu Cancer Institute, in a cohort of 34 patients, nearly all the patients completed chemoradiation course. We can see in their cohort, most of the patients was classified as early esophageal cancer. They report a 2-year survival rate of nearly 40% and a disease-free survival rate of 30%. What's the outcome in our hospital? I would like to report the clinical experience in central Taiwan. Between 2004 and 2013, a clinical data of 40 patients diagnosed with synchronous cancer received CRT or RT to both sides was analyzed, with median follow-up duration about 2 years. This table shows the characteristics of our patient. The primary tumor of head neck cancer is mainly from origin from hypopharynx. Second is oropharynx. According to TNS stage, AJC staging, most of our head neck cancer was characterized advanced head neck cancer. Also, the most of our esophageal cancer, 2/3 of our esophageal cancer patients were classified as stage 3 and stage 4 cancer patients. All these patients was treated with IMRT or 3D CRT with overall treatment interval of about 52 days. The chemo regimen combined is very heterogeneous, but many use weekly cisplatin, or some patients use PF-based regimen. 4 patients did not receive chemotherapy. The slide shows the comprise of this patient. 6 head neck esophageal cancer did not comprise the treatment, while 10 patients of head neck cancer did not comprise treatment. 6 patients failed in both sides. This table shows the patient outcome. At the time of analysis, 12 patients still alive, 8 of patients without evidence of recurrent disease. 28 patients were dead, while 21 patients died of recurrent disease are local or systemic. Amazingly, 5 patients died of aspiration pneumonia during the radiation course, more than 10%. 1 person had aspiration pneumonia after radiation without evidence of recurrence. This is the survival curve according to our patient cohort. We can see the overall survival, median overall survival is only 6 months. When tumor was stratified with early, late esophageal cancer or early, late head neck cancer, the survival curves did not seem significant change. 19 patients was observed had aspiration pneumonia during or after the radiation course. So we further analyzed the risk factor associated with aspiration pneumonia. We find that this adverse event mainly occur in old age, tumor recurrence, tumor status. The echo status or performance status did not affect, or staging did not change the risk of aspiration pneumonia. This is the study conducted in our hospital. We analyzed nearly 600 patients received concurrent chemotherapy for head neck cancer. We found nearly 7% of patients had a symptomatic aspiration pneumonia during the RD course. Once patient had the symptomatic aspiration pneumonia, nearly 1/4 of patients have to terminate the treatment or die within two months. This study also conducted in our hospital. We used the universal insurance claim data of Taiwan. We analyzed more than 50,000 patients. We identified a similar finding. Nearly 5% of patients have pneumonia during or soon after the radiation course. If we analyze the risk factor, we've also found the all age group and the tumor size of oropharynx and the hypopharynx have a higher risk of aspiration pneumonia. So, if this patient was treated with extensive radiation to both sides, according to our data, only 12 patients meet this criteria. We can expect to still have a chance, 1/4 chance to survive. His expected life expectancy is about 10 months. So the result is still not satisfactory. So my conclusion is, patient care, due to the poor prognosis for patient care, formidable challenge for patients with synchronous cancer irradiated with extended field. The risk of aspiration pneumonia should be minimized when large volumes of aerodigest tree was encompassed by the radiation field. So we should minimize the radiation field as possible as we can. I think 3 approaches can reduce the radiation pneumonitis. First, we can constrain the dose to pharyngeal constrictor. Of course, for this case, it is not possible because the tumor is located in basal tongue. The second is patient education. When patients have grade 3 or grade 4 esophagitis or mucositis, they should be educated to have high risk of aspiration pneumonia. The second approach is use prospective video fibroscope to screen the high-risk patient. Finally, due to the heterogeneous pattern of presentation and limited sample size, I think we should conduct a multi-century trial to examine the efficacy of novel treatment strategy. This is my presentation. Thank you for your attention.